Greetings. My name is Eric Lassie, and welcome to my session of the Digital Pathology Association's Virtual Symposium for 2022. The title of my talk is Looking Back: How Digital Pathology Can Influence Your Career Path. I want to thank the organizers, Dr. Lewis Hassel and Dr. Alan Rampey. They've been good friends for many years, and I thank them for inviting me to this symposium. I was a little concerned, though, when they first asked me, because they said, your talk should be a look back, a reminiscence of digital pathology. And, usually when you're asked to give an historical perspective, it's because you're old. You've been around for quite a while, and you've had a chance to make mistakes and hopefully make some contribution that's positive. But I thought, oh gosh, how can I do this? And I came up with the idea of creating some greatest hits for digital pathology. As background, I'm a member of Affiliate Pathologist Medical Group, 40 pathologists covering 3 states. Most of us are in Southern California. I am very active in the College of American Pathologists and also the Digital Pathology Association. And finally, I'm a trustee of the American Board of Pathology. These are the works I'm most proud of, color atlases that I've done for the CAP. I've edited and illustrated these. Latest one is on bone marrow, and it should be available in the next few months or so. My conflicts and affiliations are listed here. None of these products will be promoted, and I have received no commercial compensation for this talk. Okay, now let's look at excerpts from previous talks. Blast from the past. Tools evolve over the years. In pathology, we've evolved as well. Many of you may remember Kodak slide carousels, and now we have e-pathology. And that term is a bit outdated, as now we talk about digital pathology, our future. So is that really going to happen? Will we transform our practices through digital? Well, I have a confession to make. For many years, I thought this whole digital stuff, this digital transformation, was just hype. It was hocus pocus, a clever magic trick. But it really wouldn't impact my practice. I viewed whole site imaging something like this. Not quite real. Or how about this video? To be honest, I really didn't want a digital scope. For me, whole slide images were putting glass slides into slide holders to project low power views at tumor board. My pathology group had a private lab, and we bought a scanner, but it really wasn't being used. It sort of was gathering dust there. So what changed my mind? Why did I get more involved in digital pathology? Well, it started with large box labs advertising virtual IHC. We had a very good IHC lab, and it was competitive. We had a number of labs that were quite a distance from our operation, and LA freeways being what they were, it would take a while to get the slides, the glass slides, IHC slides delivered to our clients. One of our good clients out in San Bernardino, about 2 hours drive from LA with traffic, wanted their slides by 7 in the morning. So I came over to the lab to work on a virtual IHC project. Slides were ready about 4 in the morning, and we started scanning them. And when that was done, we boxed them up and gave them to the courier. So the virtual slides were ready early, and the glass slides made it to the lab by 9. That convinced me to give up rotating objectives and focusing knobs for pinch and zoom. I'm convinced that the father of pathology, Rudolf Virchow, would have adopted digital pathology. I want to pause here for a moment and add a comment about digital pathology. Digital pathology began well before whole-site imaging. Digital cameras replaced film cameras, and these striking images could be incorporated into pathology reports and presented at tumor board. All right, first in the hit parade is tumor boards. These conferences have a long and storied history. Here's a couple of cases that I like to show that demonstrate the power of whole-site imaging. Case of breast with suspicious calcifications, thought at first to be malignant. Core biopsies were performed, and you can see as we zoom in on these areas of microcalcification, they have quite a bit of substance to them. They're rounded, and a couple have little spikes on the edges. So this obviously is not carcinoma, but in fact, what was thought on radiology to be malignant is schistosomiasis. These are Schistosoma mansoni eggs in this elderly Filipino female presenting with calcifications. Next case is a patient with a renal mass, and cores were taken. Radiologists complained that all we could read on these were necrotic fragments. There's one little area of perhaps increased cellularity, but otherwise we couldn't make a diagnosis, and that did not make the radiologist happy. The surgeon went ahead, because it was a mass, and removed the kidney, and there was a cortical lesion here, but the main mass was in the lower portion of the kidney, which showed a central necrotic mass as seen on the gross image here. And when we showed this at tumor board, we pointed out to the radiologist that the reason we couldn't make a diagnosis on the core biopsy was because the whole central lesion where they sampled was necrotic. And moving around virtually, we could show other areas that were more cellular, more toward the cortex, and these are diagnostic of renal cell carcinoma. So the moral of this little vignette is that the needle may be in the lesion, but the lesion may not be in the needle. So why whole-site imaging? I think these two cases illustrate how powerful whole-site imaging can be at tumor board. You know, it's all about telling a good story, and whole-site imaging just allows the pathologist to be front and center and present that story and the hard work they did in working up a case to the clinicians and surgeons. So what's the value proposition of using whole-site imaging at tumor board? Well, it allows pathologists to have greater exposure. communicating their cases. It's where we interact with our clinicians and we put our skills on display. And it's where we can have a direct impact on patient care by participating in the dialogue. A number of studies have shown that clinician participation and satisfaction are increased when whole slide images are used at tumor board. Now we turn to education. Some of these examples are from a talk I gave at the DPA 2 years ago. Whole slide images have been used effectively in journal articles. Here's an example from archives from a few years ago. In one of the articles on large cell carcinoma of the lung, the authors effectively used QR codes that linked to whole slide images. This allowed readers to evaluate the entire slide, not just a single region of interest that was printed in the article. I'm a big believer in making textbooks as interactive as possible. That makes them more interesting and provides many teaching opportunities. Here's an example from the Color Atlas of Hematology that I illustrated and was a senior editor. We have over 120 QR codes throughout the book, and scanning those codes leads you to the specific areas of interest, but also the entire peripheral blood smear. I'll take a tablet and scan one of the QR codes, which links to the digital scope navigating software in my browser, and I can now view individual cells in context. Educational conferences are also ripe for whole slide imaging. So in this old-time photograph, who's missing from this group of esteemed pathologists? Well, it's the one person sitting at home attending the conference virtually, which we're now all quite experienced with. During the pandemic, virtual learning was the norm. We had many opportunities to attend courses in person as well as remotely. For me, I'd like to see this idea expanded so that at conferences, when an individual case was presented, there'd be a QR code up on the screen. You scan that with your phone or tablet and immediately review the entire teaching case. Here's a mock-up I did for the CAP, which gave my vision of how hematology cases could be presented at the national meeting. Here's case 1, 44-year-old female with leukocytosis. The PDF was interactive, and tapping on the image took the participant to digital scope viewing software, which opened in a browser. The entire peripheral smear could be examined and individual cells seen in context. The rest of the discussion was on neoplastic and non-neoplastic lymphocytosis. I've also been a big proponent of QR codes on scientific posters. It's gratifying to see this idea take off and the QR codes linking not just to a download of the PDF, but also to the author who can present the case virtually. It's pretty obvious that I'm a proponent of QR codes and have used them well before they became commonplace in the pandemic. I made up a number of almost like business cards, which use QR codes to link to individual cases, and I've used that in teaching conferences for histotechs and other laboratory scientists. And for the Royal College of Pathologists in Australasia, I put together a book about resources, again using a large number of QR codes, talking about the CAP's HistoQuip program, Path Presenter, and the use of QR codes as links to whole slide images of peripheral blood smears in a CAP atlas, as I've shown previously. Another educational opportunity using digital technology includes virtual autopsies. These have become more important during the pandemic and as the opportunity to perform real autopsies has decreased in many teaching programs. There are also augmented reality apps such as this one from 3D4 Medical. The detail is amazing, and this app can be used for teaching and other educational courses. And this virtual reality program can be used to teach medical students, pathology residents, and might even be used in tumor conferences. Here's an example of an interactive notebook. What a great way to learn anatomy. So why use whole site images in education? The value propositions are many. Whole site imaging allows for an immersive, interactive experience with greater retention of learnings. Regions of interest can be viewed in context, and new learning paradigms can be supported, such as flipped classrooms. In addition, the American Board of Pathology has now gone totally virtual, and this is another reason to become familiar with whole site images. Moving on to digital consults and quality assurance. Pathologists love to share cases in small groups or large groups or even larger groups. And if that's not enough, we can always send the case for consultation via FedEx or UPS. Pathology is best looked at as a team sport. It's an opportunity to engage the collective minds of so many talented people. It's best practiced in a consultative environment. And following the theme of this symposium, pathologists must break the tyranny of glass and no longer suffer its constraints. Whole site imaging cuts the chain and gives us a passport to share cases throughout the world, allowing us to create a worldwide referral network of pathology experts. It democratizes pathology. It expands our reach. Whole slide imaging also allows us to have a more robust quality assurance program. The College of American Pathologists and National Society for Histotechnology have partnered on the HistoQuip program. This has numerous whole slide image links to poorly prepared tissue and explains mitigating factors to prevent this from happening. So why WSI for consultations and QA activities? The value propositions are faster turnaround time for cases, more equity and democratization of our cases. Quality assurance can now extend beyond just our local pathologists in offices next to us. And there is sharing and collaboration via social media such as Twitter, Kiko, or TikTok. Now on to primary diagnosis, perhaps the greatest hit of all. Primary diagnosis is the holy grail of whole slide imaging. Numerous studies have shown equivalency between the glass slide and the whole slide image. The FDA currently has cleared 2 systems, one from Philips, one from Leica, for primary diagnosis, and other instrument manufacturers are awaiting approval. It is important to note that the FDA does not regulate the practice of medicine, and any instrument, once properly validated, can be used for primary diagnosis. The pandemic has given a boost to digital pathology. We're now undergoing a worldwide feasibility study with real-world collection of data. To personalize this, the pandemic allowed me to move from my laboratory office 19 miles to my home and read out cases from there. Welcome to my home office. Digital slides also allow for better load balancing so that cases can be distributed more equitably. Now I want to turn our attention to the primary way we communicate, our box. It's 8.5 by 11. Let's think inside this box. What we put in it will impact patients directly. We can add images and URL links and prognostic information. But also think about reorganizing it. And perhaps a QR code that links to the whole slide image on the case so that patients and physicians can review the slide. A truly smart, interactive report. This to me would be the ultimate pathology report, including EMR data, whole slide image information, next-gen sequencing, a link to the digital slide, and then, importantly, prognostic and predictive information with recommended treatment options. These are the components of the pathology report of the future, many based on digital pathology. Final diagnosis versus disease mechanisms, prognostic information versus predictive information, genomics yielding to phenomics, a generic report versus a more personalized report, and instead of just what is the diagnosis, what should we do next? The future of pathology will be based not on just how we diagnose, but also how we predict disease. The better the prediction, the better the prognosis. We must anticipate our patients' needs by moving from diagnosis to help plan therapy, and digital pathology can definitely be of assistance. Why whole slide imaging for primary diagnosis? There's improved workflow. We can now sign out remotely. There's the opportunity for load balancing, and finally, truly integrated smart reports. Last and most exciting, we have artificial intelligence and machine learning. Over the last year or two, there has been a veritable tsunami of articles on artificial intelligence and machine learning. Assisted or augmented intelligence, as it is sometimes called, has the potential to make our lives so much easier. It can help with counting and measuring and localizing metastases and infiltrating lymphocytes and help us classify and grade tumors. Pathologists, after all, are seekers and counters. We measure depth of invasion, we count mitotic activity, and we hunt for organisms. And some things can't be done manually, like determining the microenvironment. I anticipate a time when magical apps will transform our practice. I've done talks about the future of apps, and I always conclude with the one app to rule them all, which I call Samwise, because Samwise Gamgee was the best sidekick ever. No matter how difficult the task, Sam was always there to help. And of course, the app would be available in 3 versions, from free all the way up to the Deluxe Pro version. So let's take a look at what the app would actually do. That is Samwise. You have full case integration, full workflow integration combined with Google Assistant. These apps are truly magical. And this is how our day would begin.
Cases to review. 18 of them are complex and will require extra time. Digital scans were done on 20 cases. 2 cases are colon carcinoma resections with lymph node dissection. I've reviewed the lymph nodes for you and analyzed them for metastases. Here is the workload breakdown of the new cases. Incidentally, there are 2 outstanding cases. The molecular studies are complete and you may be able to finish those as well. Shall we begin?
I love that, starting the day with "Shall we begin?" So, why whole-site imaging for artificial intelligence? More and more artificial intelligence apps are being developed. These AI and ML apps will become a necessity. They'll automate counting mitoses and finding organisms. There's computer-assisted diagnosis and triage our workflow, making us more efficient, and finally reduce errors and improve quality. AI can take us backwards when we had more contact with patients. Digital pathology and AI can help bridge the gap that divides us. And for patients, it can mean a closer bond and a greater appreciation for what we do. In closing, I have a few final thoughts I'd like to impart. I've given you many reasons for why WSI. Look at the evolution of pathology. In the past, it was H&E data and SAGE-based diagnosis and intuition. Today, it is IHC and molecular data and evidence-based decisions. In the future, data will be algorithm-based and our actions will be precision-based, all supported by artificial intelligence. Look at human progress through time, and look how far we've come. And AI will only make it better. Medical knowledge has increased dramatically, and we just can't retain it all. In 1950, medical knowledge doubled every 50 years. In 1980, every 7 years. In 2010, every 3.5 years. In 2020, every 73 days. And the pace continues to accelerate. In 1930, we had 2 types of blood diseases, and now we have over 70 leukemias alone. And we're going to need more than Google to keep up. AI and machine learning can help, and both of these require digital pathology. We really have to adapt and adopt. And here's an allegory that emphasizes that. It's about Kodak. Before its collapse, Kodak was much like Google. Film was manufactured in Kodak Park in Rochester, New York. The campus was a homage to film. Kodak started in 1891 and was responsible for many innovative breakthroughs, including the invention of the instant film camera and superglue. But in 2000, innovation stopped and Kodak eventually filed for bankruptcy. For the reason, let's return to Kodak Park. There are 59 buildings in the park. As the film industry shrank and people moved to digital, how many steps do you think it took to make film? It took 59 steps, and Kodak couldn't become more efficient, and Kodak Park was demolished. Ironically, it was all recorded on film, digital film, and the lights went out at Kodak. Digital pathology offers many new opportunities for pathologists. Residents and fellows should prepare for the future because of these growth opportunities. You can add to your skill set. When you come to a new practice, you're expected to be IT savvy, to know molecular, and to have fresh ideas as well as know digital pathology. But what puzzles me is that with all this talent, we tend to stay in the background, to be invisible to our colleagues. Why do we work so hard to avoid the limelight? It wasn't always this way, though. Pathologists were once the Google of medicine. Clinicians came to us for answers, and we often had the largest set of books outside of the hospital library. And here's another analogy: the importance of the Rosetta Stone, which translated hieroglyphics into Egyptian and Greek. And this is not much different than this: clinical actionable biomarkers. Pathologists need to make molecular data understandable to clinicians. This is a new and important skill. As precision medicine becomes more dominant, pathologists need to be there to help and to guide our colleagues and our patients. They have many questions, and we should be there to answer them. Artificial intelligence and digital pathology can help us with that task. We can promote our value by being integrators and interpreters of laboratory data. And we can use these tools to improve quality, be more efficient, and identify clinically actionable knowledge. Consider for a minute the word technology. It is based on the Greek term technos, and it means weaving. In ancient Greece, weaving was considered one of the highest skill sets and art forms. We need to embrace technology and be weavers of information. Precision medicine, next-gen sequencing, digital pathology, and now artificial intelligence are all woven into the fabric of pathology. Digital pathology will elevate your practice. It certainly has elevated mine, and it is not a difficult skill to master. Consider your future and the transition from glass to digital. Analog is no longer an option, as Keith Kaplan has stated, and I hope I've shown you that whole-site imaging is value added. Leveraging these digital tools will increase your visibility and enhance your career. We are witnessing a digital evolution, almost a revolution. And here's my advice. Stand out from the crowd and engage. Communicate your worth. Think outside the box. Don't settle for expediency. Leverage digital tools to increase your visibility. And finally, be a Rosetta Stone, a guide for your clinical colleagues and your patients. And that's your superpower, and digital pathology can help you get there. And the DPA can help you be not just one pea in a pod, but a pearl of great value. In closing, consider the glass slide. What can you do with it? Think about it. Well, you can diagnose it, you can focus it, you can store it, or not. You can break it, you can replace it, you can annotate it, QA it, measure it, or things on it, count things, hunt for things, and share it. Or you can scan the slide, digitize it, and do so much more. Digital offers many more advantages over glass slides. So look beyond the glass to life without glass. A digital life that, with the help of AI, promises to transform your practice. Consider tissue's remarkable journey from patient to biopsy to processing and embedding and sectioning and staining and finally the microscope. But there's so much more when you add digital. We've got education, tumor conferences, remote sign-out, pathology reports, computer-assisted diagnosis, consultations, load balancing, virtual immunohistochemistry, multiplexing, phenotyping, frozen sections, biorepository, QA activities, image analysis, artificial intelligence and machine learning, and finally archiving. These are the value add of digital pathology. All right, thanks for joining me for these digital pathology greatest hits, and all the speakers will be around for live Q&A. Thank you.